Buongiorno.
Buongiorno. Ladies and gentlemen, welcome to our weekly Distinguished Speakers series organized by the Center for Translational Vision Research at the UCI. I am Marco Bassetto and I am postdoctoral fellow in the laboratory of Professor Kaiser here at UCI. It is my pleasure to introduce the speaker of today, Dr. Donny W. Dr. So is a professor and chief of pediatric ophthalmology in the Department of Ophthalmology here at UCI. And he is also working at Children's Hospital of Orange County. Dr. So started his career by receiving his Bachelor of Art in Biochemistry from Rice University in Houston and his medical doctorate from Baylor College of Medicine, Houston. He completed his residency at the Eye Institute of the Medical College of Wisconsin and later his Pediatric Ophthalmology and Strabismus Fellowship at the Wilmer Eye Institute at the Johns Hopkins University. Before joining UCI, Dr. So worked at the Children's Hospital of Omaha as Chief of Ophthalmology Service and Interim Surgeon in Chief. Also, he served as a John and Irene Geder Endover Chair and Professor at the Department of Ophthalmology and Visual Sciences. Since 2000, Dr. So is actively involved with research with the Pediatric Eye Disease Investigation Group, which is sponsored by the National Eye Institute. Among his numerous prestigious appointments, Dr. So served as chairman of the annual meeting program committee in pediatric ophthalmology for the American Academy of Ophthalmology and in the annual meeting program committee for the Association for Research in Vision and Ophthalmology, ARVO. He is an executive committee member and a chair-elect for section of ophthalmology of the American Academy of Pediatrics, and he has been voted best doctor in America and American top ophthalmologist since 2003 to present. Dr. So has been inducted to American Ophthalmological Society and has been voted Inventor of the Year in 2019. Dr. So is the inventor of several surgical equipment and medical devices. From March 2016, he became a chief editor for Medscape Online Reference, and he published over 100 articles in major journals and chapter of textbooks. Ladies and gentlemen, it is without any further ado that I invite you to welcome Dr. So and follow his lecture.
Thank you very much. Great, that was a great introduction. So let me just make sure. Can you see my slides okay, everybody?
Yes.
That's great, thank you. This is truly a great honor. I try to attend many meetings, but this is actually one of my favorite venues, and because I learned so much, and I'm truly humbled with all the research that's going on and all all your effort. So I'm actually excited to give a talk for many reasons, but I actually look forward to many feedbacks from all of you. And see how we can actually work together and improve the care of children. So without further ado, for the next, I'm going to say about 40 minutes, I'm going to be giving a talk on the research that I'm doing, and then we will reserve about 30 minutes for further discussion. So I'm going to just tell you about what is it that I do. First, I get consulted to do retinal exams on pediatric patients, especially these young patients. So I'm going to show you a picture of 3 cases here. One of those pictures represent a completely healthy child with no medical problems whatsoever. And patient just was born vaginally. And so this is actually one of the findings of normal vaginal delivered retinal hemorrhages. So that child gets to go home without any problem. Another child actually has a brain problem, increase in intracranial pressure from a medical condition. And so I actually need to get an imaging studies and consult neurosurgeons immediately for a surgical intervention. And one of those cases, and one of those 3 pictures represent a child that had been unfortunately abused, and the child needs to be protected. So we need to contact the social services, the law enforcement, and it's going to cause a tremendous stress on the family for many reasons. So here I am. I'm given this responsibility to determine the cause and also what is it, and to interpret these images. And the problem with this is that there's no consensus on the pathophysiology on the retinal findings in abusive head trauma as of right now. And also, even when you have a same image, there's a significant disagreement. Just a few weeks ago, as you recall, Michael Chang gave a very nice talk on interpretation of retinopathy of prematurity. And he talked about these physicians who have 20, 30 years of experience having disagreements of what is ROP and what isn't, and who needs treatment and who do not. And actually, unfortunately, this is the situation is no different. So first, before I start, I want to thank, this is truly a team effort. I truly have been surrounded myself with the people that are a lot smarter than I am. And as you can see, Dr. Minkler is in our audience, just world renowned, but we have many others, as you see here. And actually, there are more people that I'm going to be actually working with across the world. And let me tell you why we have to work with people around the world in just a little bit. So I want to just give you just a little objectives, because I'll be talking about a lot of stuff, and I want to help you to focus. What is it that I'm going to be talking about? So first, I want to talk about the past, present, and future of abusive head trauma understanding, and the current research that's going on today, and then where are we heading tomorrow? So that's the big overview picture. So I want to present to you a case that I'm actually exposed to very frequently. So this is a typical scenario. 6-month-old child comes in with a fever, vomiting overnight, and then started having seizures, and the CPR was initiated. And patient came in just like this, comatose. And we're consulted frequently to look at the retina because they want to see what's going on in the brain. Because as you know, by looking at the retinas and back of the eye, you can tell a lot about what's going on in the brain. And this is what it looks like. There's just diffuse hemorrhages everywhere. That's all you see. So based on this, I have to make a documentations and recommendations of how to proceed. Before we do that, we have to think about all the differential diagnoses, and each one of these conditions, as you all know, we can talk about it for an hour. But I'm just going to tell you briefly that we have to go through extensive differential diagnosis and also extensive workup before we come up with the possible diagnosis of abusive head trauma induced retinal hemorrhage. Now, what are some of the confounding and complicating factors? Normal vaginal delivery, retinal hemorrhages occur up to 50%. And we actually have published a paper on this topic. And in Korea, we looked at 50,000 children, these are healthy babies, and we found that up to 50% of those patients actually had small amount of retinal hemorrhages that we would have missed. And sometimes the retinal hemorrhages can be very mild, but it can look like the ones on the right, very extensive. Now, how do you tell the difference between this and this? Like what are some of the things that you have to look for? So it can be very tricky. And also another confounding factor is that this is a retinal hemorrhage, but within just a week, it can actually look like that. So timing of the examination is extremely critical as well. So there's a lot of factors a lot of moving parts that go into this. Now, why is making an accurate diagnosis important in this situation? If you could imagine the false positive, that impact on the family can be tremendous. So you have incarcerations, separations, social work involvement, but the false negative is just as devastating for the family, because now we're putting this kid back into the danger. So it is very important for us to be very conscientious and very intentional and very thorough with our investigations and workup. Now, let's just a brief history. The first case of abusive head trauma was in 1800s, many years ago. And it was not till 1950s when pediatric neurosurgeon had cases of shaken baby syndrome, where the baby had been shaken and developed a significant brain injury. And then 1962 was when Henry Kemp, who's a pediatrician, became the father of the child abuse specialist. And he first coined the term battered child syndrome. And later, we had a pediatric radiologist talked about what are the things that you can actually detect to help you with the diagnosis. So since 1960s, when the field of child abuse was established in pediatrics, it actually went through many different names. Battered infant. As a matter of fact, when I was in training, there was no term, such a term as abusive head trauma. There was no term as a non-accidental trauma. It was shaken baby syndrome. And when Dr. Minkler was in training, and it probably was called whiplash, shaking infant, or battered child syndrome. Okay. Now, then you may say, why was the shaken baby syndrome or abusive head trauma cases so rare before 1960? So, like, why did it take that many years before, before this field was created? Medical journal, our journal that we read, ophthalmology, and these medical journals were actually started in 1700s, and there was no single case of retinal hemorrhages or the child abuse even. Well, that was because the English common law stated that children were properties of the fathers. So if something were to happen to the children, it was like something happening to your livestock, like your dogs or cows. So it didn't deserve any type of further attention. And there was no organization as a law to protect children until 1960s, when American Society of Prevention of Cruelty to Animals. As a matter of fact, before 1960s, the animals actually had more protection and more rights than children. This is actually kind of shocking for many, but that is the truth. That's the history. Now, how common is this problem? And I'm just gonna sometimes when you're doing research and it's kind of hard to see like what's actually going on around the world. 6 million children per year have reports of abuse. So that's over 16,000 children per day in this country. Just think about the number. And of course, thank goodness, majority of these kids do not have retinal hemorrhages and significant brain injuries. But if for those people with a diagnosis of abusive head trauma, even if they survive, it's an uphill battle for these kids, because 80% of the survivors have a permanent sequelae in some form of developmental delay. And then we speculate about 30% of these cases go undetected, because when you shake these children, there's no physical manifestations. You don't see anything. So when they go into coma and they wake up, well, they're not going to seek for any medical help. And also this COVID, this actually is this COVID actually is making many people nervous. But for me, it's making me nervous for a different reason. Many family members are under tremendous stress, and they're confined in a very small space. And so we speculate that there's an increased number of cases of these abusive head trauma during this COVID time. And of course, it's still not, we don't know for a fact. Your question, one of you may question, like, why is this condition still very common? I mean, we have a child abuse specialist that was developed, that was actually formed 50 years ago. Like, why is it so common? Well, I'm going to show you a map here. The darker the color, the higher the incidence, prevalence of abusive head trauma, and you can see the concentration. where we live right here, we have the highest concentration and of these cases. So we really have to wake up. And then what are some of the other causes why this problem is so common is that there's a lot of doubt. As a matter of fact, there's a movie made that doubts the very existence of this condition called the syndrome. But there is a Forbes magazine, newspapers, TV. This is what sells. This is like what excites people. It's like, you know what? Medical community is wrong. We are right. So unfortunately, there's a lot of force that doubts the existence of this condition, and also the researchers. They have experimented with pigs, lambs, monkeys, but they cannot induce retinal hemorrhage. It doesn't matter how hard they shake, they cannot elicit, they cannot generate it. Like so, and as a matter of fact, on one paper, it says that the force that's needed to cause retinal hemorrhage in these animals or human would not be compatible. If you were to shake the child that hard, their neck will be severed. Their spinal cord will be separated. It would not be possible. So this is the situation that we're in right now. And also in some cultures, some countries, there isn't a single case of a child abuse reported in their history. I just think about that. Think about that. But in my opinion, the main cause is just lack of awareness and education to the public. This is truly a public health issue, in my opinion. So let's dive into the pathophysiology. And as we talked about, there's a lot of controversy for the brain injury. We have a pretty good idea why they have developed these subarachnoid hemorrhages, with the brain sliding back and forth with a coup and contra coup force and rupturing the bridging vessels. But what happens to the eye is still a mystery. Why so many of these babies who develop these subarachnoid hemorrhages develop retinal hemorrhages? Because the eyeball is actually cushioned. And also, why do these babies develop a special types of retinal hemorrhages, which actually we're going to talk about? So possible theories include increase in intracranial pressure, with the pressure being transmitted to the optic nerve and to the vitreous space. Another is a vitreoretinal traction. Now, what does that mean? So we have this vitreous that's inside the eye that's actually relatively heavy in relationship to the thickness of the retina. And as this vitreous is sliding back and forth in areas where the vitreous is attached to the retina, it can, as it tears, it can result in hemorrhages. So the OCTs have shown very nicely in areas of these hemorrhages, you can see a focal vitreoretinal traction as well as a posterior vitreous detachment. And also, and you can see on this cadaver eye, you can see this retina being pulled with the traction with the vitreous. And many people like to use the term shearing force. So what is a shearing force? So let's talk about this. It's a shearing force is an unaligned force pushing one part of the body in one direction and another part of the body in opposite direction. That's what we call the shearing force. But it's actually a lot more complicated than that. So I'm going to just show you a little video. This is an hourglass with the oil on top, water on the bottom. You could shake this thing as hard as you want, okay? That interface between the oil and water will not be disrupted, just similar to the vitreous and retinal attachment. But when a baby's shaken, as you can imagine, the baby's held at a torso, and then you go like this. There's a torsional component. Now, when there's a big difference between a translational and a torsional force. When you actually exert a torsional force, due to the significant centrifugal force, the force is multiplied by about 20. Okay. So what does that mean? So I'm going to show you I'm just going to gently hold this hourglass and just with minimal effort, without significant displacement, that interface can be displaced very easily. Okay. And when but the problem is that when I go to court to to support the prosecution as a medical expert, my number one question is that how much is that force? How hard do you have to shake? A child that's sitting in a car seat going through a road that's not well paved, that simple vibration, is that enough to cause retinal hemorrhage? Doc, and how do you know that doesn't cause retinal hemorrhages? Also, a child that's falling, babies fall all the time. I'm just going to tell you, I hate to admit it, but there are times that you hold a baby, but they slip, they just move around and sometimes they slip. And so is that enough force that can cause retinal hemorrhage? Well, so my objective was to determine that force. What is that force? So that's when my study started back a few years ago. And my goal was to determine what is that vitreoretinal adhesive force, that internal limiting membrane, which is the footplate of the Mueller cells, to the posterior limiting membrane of the vitreous. What is that force of that attachment? And also, by shaking a child, would that create a force that's significant, that's greater than the vitreous retinal attachment to cause separation, which would result in retinal hemorrhage? And also, I wanted to explain why these babies have certain patterns of retinal hemorrhages. Why do they have perimacular? It's not like you may think this is like, many of these babies have actually retinal hemorrhages in entire areas of retina, but many times it's actually, has a very specific geographical patterns. And also the retinal hemorrhage is not localized to the posterior pole, but it's very diffuse into the aura. And then why do some of these babies actually have retinoschisis and macular folds? And most importantly, why do they develop these retinal hemorrhages in different areas? For example, we have these superficial retinal vessels that's transversing over the retina, just right next to the internal limiting membrane. And then these blood vessels invaginate into the retina, you see, into the inner retinal layer. And so some of the retinal hemorrhages occur superficially. Some of the retinal hemorrhages occur, as you can see here, and some of the retinal hemorrhages occur within the retina, So because of the ganglion cell layers are compactly packed, and you see these splinter hemorrhages along the nerve fiber layers, or you could see a localized dot retinal hemorrhages. Or sometimes you can actually have bleeding within the choroid capillaris, resulting in subretinal hemorrhage. But as most of you do research on retina, there aren't too many conditions that cause retinal hemorrhages in all three layers simultaneously in multifocal spots. There aren't that many conditions like that. Yes, there is macular aneurysm. There is a choroidal neovascular membrane, but those be extremely rare in infants. And also, remember, I just told you, it's in multifocal areas. So why is that? Like, why is this so different? And the differential diagnosis can be quite extensive for various retinal hemorrhages, but none of those conditions cause retinal hemorrhages in all three layers in multifocal areas simultaneously, except for trauma, okay? So so I wanted to determine using an animal model similar to human, and I wanted to first determine that vitreoretinal adhesive force. So what we did is that we went to the lamb. Why lambs? Well, because the eyes from the young sheep have a very well-defined retinal structures, and they're holoangiotic, unlike the birds. We're gonna, sometimes like Dr. Minkler and I, we actually had a talk about woodpeckers, like, why don't they develop retinal hemorrhages? Well, guess what? The retina does not have blood vessels. There's no blood vessels. There's no vessels to bleed. And also their retina is much thicker. So the vasculature is actually similar. And also the dimensions are most similar, is very similar to humans, even compared to monkeys. And their hyaluronic acid and collagenase vitreous composition is actually very similar to neonatal human eyeballs. And this actually had been well studied starting 2018 by my colleague, Dr. Coates from University of Utah. So what we did is that we actually performed a nice small sclerotomy, 8 millimeter from the optic nerve, and then made it 5 by 5 millimeters. And then we went further away, 20 millimeters away from the optic nerve, and we made another opening further away, because I wanted to see what the vitreoretinal attachments forces are in different areas of the retina. And we actually repeated this 5 times. And you can see we made an opening, and then we scored the retina. And then we found this very nice material, PTFE. And it's a pad, and we attached it to the retina, and we glued it. And we actually had to go through every single glues out there and to find the right glue, because some of the glues actually can actually create an exothermic reaction, like the cyanoacrylate, and it heats, and then it can distort the anatomy of the retina. And some glues do not work very well in wet situation. So we found the best the glue, and then we put it on a load cell, which is a transducer that converts the force into an electrical output. And then we separated the retina slowly from the vitreous, 180 degrees direction at a constant velocity with y displacement in a constant temperature. Okay, so here is how we do it. And then you can see, I'm going to just, I'm going to show you a video. Okay, I cannot show you the video. Anyway, so I'm just going to say that as these, the PTFE that's actually attached to the retina, as it separates, we're actually registering the force that it creates. This is actually registering the force that it's needed to separate the retina. And then this is before and after. And we confirmed the retinal tissue was adherent to the pad through an histological examination. The result, now this is the important part. We found that the 8 millimeters from the optic nerve, which is actually almost at 0 degree, meaning it's almost perpendicular. The average stress was 2.72. But when it was 20 millimeters away, remember now the eyeball, because of the shape of the eyeball, now it's almost like 45 degrees, like this. So in that location, it was actually greater. And partially, most likely, it was due to it incorporates some of the shearing force as well. So it was somewhere between 2 to 4 kilopascal. And this was repeated at a different angle. And overall, we found that it was somewhere between 2 to 5 kilopascal. And we repeated this with the rhesus macaque monkeys. And the unique thing about the monkeys is that their retina is most similar to human, including the vitreoretinal attachment points, including the macular, perimacular, optic nerve, the vessels, and the aura. And then we repeated the procedure with the same, same method. And you can see we're separating it gradually and then separate it. And we repeated in a different angle. And what we found was a number was even lower. It was a 1.2 to 1.3 kilopascal. So now we determined the vitreoretinal adhesion force. Now we wanted to determine, now would a shaking an eyeball would cause a force that's great enough to overcome that force between 1 to 5 kilopascal. So we created a computer simulation model with a group of very smart people, biomedical engineers, and we created a finite element that would incorporate all the ocular tissues with its own characteristics and properties. And then we subdivided the eyeball into 300 different focal points, where each one of those focal points can be analyzed simultaneously down to 0.001 seconds. Okay. And then also we created an attachment point along the blood vessels to the vitreous, to the retina, because of course, whereas there's an attachment, is going to have a different amount of force. And then on top of that, we subdivided the retina into 3 components: subretinal, intraretinal, and also pre-retinal. Okay. And then once we had this computer simulation model, of course, we had to exert force. Well, how do we know what the shape of the eyeball, what pattern the eyeball is going to be shaken? Well, we went to a Yamazaki model that was actually already experimented, and these very smart people created a baby doll with the monitor that was built inside the baby doll's eye, and also the perpetrator's hand. And they shook this baby doll in a certain pattern, and this is what it looked like. And so this is the position of the eyeball in a figure of 8, in a torsional component, you see? And so that's what we did. We actually repeated with this computer simulation model, we imitated the position of the eyeball in this fashion, shaking an eye at 2.2 hertz, because that's what's realistic, 2.2 cycles per second. So if you think about it, 2.2 cycle, it'd be a bit almost like this. It's not this, it's more like this. So the speed that's about the speed that you would shake a child. And we created a heat map and see exactly where the forces were being applied at any given second. And we measured it in pressure, force over the area. And the unit that we used was a kilopascal. And remember, 1 kilopascal pressure is about a pencil sitting on a table. That's about 1 kilopascal. Just kind of have that in your mind, okay? And what we found was that average stress was actually 7 kilopascal along the vessel. But what's even more interesting was that wherever there was a bifurcation, the force increased to 9 to 10 kilopascal. Wherever there was more bifurcations, the force increased even more. Well, that's partially because there's more attachment points. The vitreous is attached to a greater surface of the blood vessels. So the blood vessel diameters actually do matter, okay? And also we looked at the forces and retinal layers in different layers. And what we found was that pre-retinal layer actually had just slightly greatest force. It experienced the greatest force in relationship with the subretinal. But it was not statistically significant. It was overall similar, but the pre-retinal layer had a little bit more. It experienced a slightly greater force. This explains why I think, in my opinion, we tend to see far more pre-retinal hemorrhages than subretinal hemorrhages in general, but you do see all 3 layers involved. Okay. Now, and we actually, we actually have many models. Now we have this computer simulation model. Now we can do whatever we want with it. So we actually created a soccer ball, a baseball, basketball with a certain mass, and we collide it to the eyeball, and we can measure the force that the eyeball is experiencing with different types of trauma, not the shaking, but the direct contact force. So, and we found something that was very interesting. As you can see, as the eyeball collides with the soccer, that force is propagated posteriorly. And I'm going to stop it right there. That majority of that force is actually concentrated in the posterior pole, in the macular region. And peripheral retina does not experience as of a great force. And then on top of that, you see, as that force propagates, as it touches the posterior surface and then propagates back to anteriorly, it actually creates a slight negative pressure. It's like it's a differential force. And in my opinion, and this is actually what we actually have found, and we're actually publishing this data, it is that differential of the positive and negative pressure, that differential is the cause of the traction pulling the retina that can result in retinal hemorrhages, but also retinal detachment, but more localized to one area. And as I've mentioned, in shaken baby syndrome, there's a greater force applied to the peripheral retina, but with the direct contact, it's more localized to one area. And on top of that, what's actually very interesting is that stress level through 3 different layers, they're statistically different. The subretinal layers have far less force is experienced compared to the pre-retinal. And this is actually very consistent with the clinical picture, because all the soccer ball, baseball injuries that I've seen, I don't think I've ever seen a subretinal hemorrhage that's very extensive. I may actually have seen few, but in my 22 years of experience, majority of this is intraretinal and pre-retinal. The subretinal hemorrhages in comparison tends to be far less. So I felt I was actually very happy to see this data. And also after initial contact, the pressure actually decreases significantly, but in abusive head trauma, it's not the case. It actually continuously increased with the repetition of the shaking, because the force is more additive, and also tissue undergo a greater fatigue. So the discussion is that our model supported the hypothesis that shaking an eye as a frequency as low as 2.2 cycles can potentially cause stress level that can exceed the minimal threshold for producing VR separations in young sheep and monkey eyes due to mechanical failure and tissue fatigue. And similar type of mechanical failure may occur in human if the stress level exceeds the vitreoretinal lesions. And as I've talked about, the vessel bifurcations experience far greater. In the peripheral retina, we have greater number of bifurcating vessels, much more so than the posterior pole. And this explains the diffuse nature of the retinal hemorrhages. And also, unlike the accidental or the sports-related trauma, in the shaking model, the pre-intra subretinal layers experience a similar level of stress. And this explains the retinal hemorrhages in all 3 layers in multifocal areas simultaneously. But what happens if the vitreoretinal adhesive force is greater than the integrity of the retinal tissue? In other words, what happens, I think of Mueller cells, and I have to thank Dr. Minkler for this. I actually studied, I think I've read almost every paper on Mueller cells, and more and more I learn about Mueller cells, I'm actually just fascinated. I think of this as more like it's a cell, it's a glial cell that provides some degree of integrity and structure. But what happens if that vitreoretinal adhesion is greater than the integrity of the Mueller cells? What could potentially happen? Specifically, in areas, here's an electron microscopy picture. Here's a R1, the 2 rings, R1 and R2. And you can see the vitreoretinal adhesion is actually the greatest in that area, right there, R1 and R2. And the studies have shown that as we age, these are, especially the R2, detachment becomes weaker and weaker and weaker. And also the studies have shown these the force is actually greater than the integrity of the Mueller cells. And we're actually trying to develop a computer simulation model to actually prove this. But what would happen? Well, this is what would happen. If that attachment is greater, then you're going to develop splitting of the retina at different levels, whether it's an internal limiting membrane, whether it's a inner nuclear layer, whether it's a inner plexiform layer. You're going to develop these retinal retinoschisis from a trauma. Now, if that force is even greater, what would happen? Then you're going to develop retinal folds in that perimacular area that I've actually showed you with the greater vitreoretinal attachments, especially in infants. And as you can see here. So animal models, thick. Why have we not able to replicate this model with the shaking with animal models? Well, I'm going to just tell you, thank goodness, our anatomy is very, very different than animals, even monkeys. And I've actually studied monkeys. Their neck is strong, even like when they're neonates, they're strong and thick, and it supports the smaller and lighter head of a monkey, pig, and lambs. And researchers, all the research that I've read, what they were doing was that they were actually fixating the head and moving it like this in vibration. Okay, so the neck did not influence any of the torsional component that I just mentioned to you. So first of all, there's a less displacement, less shearing force, and you had to apply a greater force. And of course, that's probably the reason why these retinal vessels did not separate enough to cause retinal hemorrhages. That's my theory. And also, human body is very different, as I've mentioned to you. The head is big and they're heavy proportionally, especially in infants. And also their neck is very soft because the spinal ligaments have greater laxity and hydration. So when you shake, the head actually almost goes 270 degrees. So there's a greater displacement and shearing force with a minimal effort. You don't have to move very much. And so having said that, so now we got these scenarios that I told you earlier. So we got cases of a normal vaginal delivery, shaken baby syndrome, a possible Turson syndrome. How do you differentiate the three? Well, I hate to tell you, even among the experts, there's some disagreement. And so that's where AI comes in. So unfortunately, here at UCI, I feel very, very fortunate to be working with an amazing group of people in a computer science department led by Dr. Peter Chang. And so we are truly one of the world experts right here. So with the taking advantage of the deep learning, and just briefly, as you know, AI deep learning is where we have the input and output, and it uses a layered algorithm to analyze the data using artificial neural network, AN. The N is each layer is assigned to a specific portion of the transformation test, and the data that we put is actually transverses through these multiple layers of these N, or artificial neural network, and then data is filtered through this cascade of multiple layers, with each successive layers using the output from the previous one to inform. So it gives you constant feedback, inform its result. So what that means is that the outcome gets better and better and better as you supply more and more data. So in other words, I think of this as kind of like a group of residents. You got ophthalmology residents, and we supply different cases of Duane syndrome, trochlear palsy, Mobius syndrome, Brown syndrome, and we provide them. And they're learning the pattern recognition. And that's what we're doing. Like when I see Brown syndrome, I'm recognizing the pattern. So they're recognizing the photos and examinations, and they're recognizing the pattern, and then they're using a real neurons to interpret that image and coming up with the diagnosis. So And when you repeat this multiple times, 1,000 times, 10,000, 100,000, million times, of course, the outcome is going to become more and more accurate as they practice more. And this is something that we can take advantage of the artificial intelligence. So the goal is that I wanted to use AI to help us with making a diagnosis and giving us a probability whether the retinal hemorrhage is from a trauma, physical trauma, or from a medical condition. So you got the input and output, and we're using the artificial neural network. We wanted to create a model, an algorithm, and then we continue to feed more and more data. And as we feed more data, the output is going to become better and more accurate. And so that's what we're doing. So we're training our AI to learn to count retinal hemorrhages and percentage of the retina, because this is something that's very difficult to do just by us. Like even with these photos, it's like, how many retinal hemorrhages are there? What percent of the retina is being covered by the retina? This is something that artificial intelligence can do at a split of a second. And what are the sizes of those retinal hemorrhages? Because studies have shown larger the size, greater the number, there's a higher likelihood that it was due to a significant trauma, hence the abuse. And then location, where is it exactly located? And also, we're training the AI to interpret the levels of the retinal hemorrhages and also the retinoschisis, retinal folds, papilledema, cottonwool spots, and exudates. And so this AI output will have it's going to be a binary system, if you will. It's going to be a medical condition-induced retinal hemorrhage versus trauma. And hopefully it will actually help us to make a diagnosis, whether it's from a CRBO, diabetic retinopathy, papilledema, coagulopathy. If it's trauma, based on based on those criteria that we're trying to help this machine learning, it can actually help us to give us a probability. What is the probability that this is most likely as a result of trauma? And then one more. It will give us a grading system of 1 to 10. And how severe is the trauma? If it's trauma, how severe is the trauma? And we're going to use our computer simulation model and animal and human studies to feed more information so that it can help us to grade better. So a force of a baby falling from a table, we know we can calculate the force that it generates on the eye using our computer simulation model. And then we can experiment that on animal models and see exactly what the clinical manifestations may be. And then based off of that information, we're going to feed it back into AI and help us to fine tune and grade it. And then with that information, the child abuse specialist will be armed with history, clinical findings, and AI information, and help them to make a better diagnosis and management. And they can determine whether the child needs further investigations or not, involving other specialists. So I hope, so that's exactly 40 minutes. I welcome any questions, and I apologize. I actually had to zoom through quite a bit. There's a lot of information, and there's lots and lots of information, research that's going on in this area. And I really want to thank you for your time. Questions, anybody?
Donny,
thank you very much.
Don Menkler, I'm curious, as you know from our discussions over the paper I've been trying to get published on shaken baby autopsy studies, I have a strong feeling that intraocular pressure may be elevated in these kids, at least transiently, based on the changes in the optic nerve, which are incredibly similar to what you see in monkeys who have artificial elevation of IOP. So at least shouldn't we be checking intraocular pressure in these kids?
Yes, Don. Thank you very much. So that's truly your idea, and I really want to thank you for your effort. And yes, the intraocular pressure may actually contribute to some of the retinal findings, but the findings that we cannot see along the optic nerve. So I strongly recommend the intraocular pressures be checked on all of these babies with a potential shaken baby syndrome that we get consulted. Great comment.
That
Thank you, Dr.
should be pretty easy with the new tonometers, right?
Yes,
Either the
yeah.
tonopen or the rebound.
Yes, checking intraocular pressure in a pediatric patients has gotten much easier because of the advent of various devices called eye care. Any other questions, please?
Okay, John.
Yes, thank you for the talk. Thank you for the talk. It was amazing listening to this very informative talk. I just had a couple questions. One question was, do you observe any like oculomotor or pupillary, like cranial nerve 3, 4, 4 and 6? Like, do you see any like ocular motor defects with shaken babies or any like nerve damage?
Yes. Okay. So many of these babies, as I've mentioned, they develop subarachnoid or subdural hematoma, hemorrhage. So you can actually increase intracranial pressure. And of the 3rd, 4th, and 6th nerve, the 6th nerve is most sensitive to the compression from increasing intraocular pressure, just because of the location of the 6th nerve. So because it's right next to the hard surface. So some of these patients can potentially develop 6th nerve palsy, but I have to tell you, John, unfortunately, many of these babies are comatose. So it's actually very difficult to, they're usually intubated. So it's very difficult to, so if they have a brain injury that's severe enough that can cause a 6th nerve palsy, usually they're going to be in coma, so they're going to be intubated. So it's very hard for us to measure, to look for a cranial nerve palsies. Good question.
Dorota.
Thank you, Donny. That was really amazing and made me think about many things. And let me ask this question. So, as you mentioned, the fact that babies are so sensitive, this is why it happens so much in them for even a small impact. I have a opposite question. So do you see the same kind of changes in the aged people, like aged retinas, and how does it translate? Maybe you can translate some of it to treatment, although there is not the same regenerative force. I do understand that.
Sure. So I'm going to say, actually, that talk, I actually can give a talk on that for 10 minutes, but I'm going to just summarize it in like 10 seconds. The reason we don't see this in adult patients as often, and as I've told you, that electron microscopy picture where there's a vitreous macular attachment, that actually resolves very quickly. Like, that actually is a remnant of the embryological development. So that attachment resolves very quickly. So you're not going to see, you could shake an adult as hard as you want, but if there's no vitreoretinal attachments in the perimacular area, obviously you're not going to develop that pulling and destruction of the Mueller cells. And that's one. And number two is that you got to be able to, unfortunately, the perpetrator has to be able to lift the baby or person and shake that hard. So you don't see this very often in anyone above the age of 2. I've actually never seen one. I cannot remember the last time I saw a shaken baby syndrome, because you got to be able to shake it hard enough to cause this degree of severe retinal hemorrhage. But after the age of 2, the retinal findings tend to be, they do have shaken babies retinal findings, but the findings tend to be a lot less severe. And then
so
also,
what about 70,
yeah.
over 70? Because this is, so I actually am thinking really aged.
Age, like a much older patient. Now, I have to say that the, theoretically, I mean, I don't see too many abuse of adults from shaking or anything like that, but I do see, 70-year-olds from a motor vehicle accident and things like that. But because of the vitreoretinal attachment, it's much less. You don't see it as often. And I would love to hear Barry's comment on that. What do you think, Barry?
We don't really see a lot of, I mean, again, the trauma that we see tends to be not in 70-year-olds. It tends to be in 20-year-olds, and it's always two guys, two dudes. It's never one dude, because our 20-year-old men never would accept that one other man could abuse them, but two always. And then we see all sorts of trauma at that point from two dudes.
Okay. So,
Okay, let's move to Jim Ho.
Well, thank you very much. It's always wonderful to have something that you knew nothing about clearly
Thank you.
explained.
thank you.
I had two questions. One is the rotation is going to be kind of about the line between the ears, and I'm wondering if there's any asymmetry in the retinal damage associated that way. I think you showed that a little bit, but I didn't pay close enough attention.
I'm going to just tell you of course, theoretically it should be symmetrical, but in most cases it is actually asymmetrical. And the reason for that is that unfortunately, when babies are shaken, it can collide with the hard surface in combination with the shaking. So if the collision occurred on the right side of the skull, you're going to actually see, now you're going to have a torsional force with a direct contact force in combination that's closer to the right eye. So you may actually see a greater amount of retinal hemorrhages in one versus the other. As a matter of fact, 20%, please remember this, okay? 20% of the shaken baby syndrome is unilateral. Okay.
Wow. The other question, sort of comment, was John Stapp, who was this Air Force guy who decelerated himself to up to 30 or 35 Gs, had I think pretty severe retinal injury, but that would be more like the stuff that Barry was talking about, I guess.
That's right.
All right, let's move to
Thank you.
Chris Kenny.
That was a really terrific talk, combination of things we've seen clinically and then where you're taking it. My question is, I was fascinated by what you said, that so many of the newborns have some kind of retinal hemorrhage, but you said they resolve really, really rapidly. Why is it that or do you have any understanding of the mechanism?
Yes,
Resolution?
Yeah, thank you, Chris. Actually, you could actually Google search it. Just put in normal vaginal delivery retinal hemorrhages and just type my name, and you'll be able to read this paper a little bit more in detail. There are actually many reasons for it, and we don't know the exact mechanism, but I do think that it's a multifactorial. And so one is that as the baby goes through a very tight vaginal opening, so there's a significant compression, not just on the soft skull, but also the eyeball as well. So there's an increase in intraocular pressure, and as well as the intracranial pressure. And then as it comes out, and as some of you may have delivered babies, when they come out very, very fast. So the difference, just like the computer simulation model that I showed you, there's that force that propagates posteriorly and then back anteriorly. It creates a small vacuum. Similar to that, as the baby comes out through that small opening, there's an increase in a complete decompression in a short amount of time. So some people think that is the initial compression of the skull and the pressure is transmitted through the optic nerve and can cause, the pressure is transmitted to the vessels and cause retinal hemorrhage. Some people believe is the significant fluctuations of the pressures of the intraocular pressure that can do it. And number three is the prostaglandin. These babies actually have a very high level of prostaglandin, and they can actually cause blood vessel irregularities, if you will, and then also coagulation factor issues. And also all babies have vitamin K deficiency. So their blood tends to be very thin. So, but
Particularly interested in the resolution.
Sorry. Yeah, I was going to get to that. Yeah, I was going to get to that.
Oh,
so sorry. I wish I could the answers are actually not so simple. So The reason these blood vessels, and our studies have shown it resolve within days, it's actually very, very quick. And the reason why it resolves very quickly is that it actually, most of these bleeding is actually intraretinal. It's within the retinal vessel. It's within the retina. And just in general, it's not just for neonates, but also for shaken babies. These intraretinal hemorrhages tend to dissolve the quickest because the blood vessels are right there. So the blood just came out of there and it's going to get absorbed very quickly. So it tends to get resolved within 2 to 3 days. So when you examine these babies a week later with the intraretinal hemorrhage, they're pretty much gone, almost in all situations. We only had one case where it lasted for 3 months because what happened was in this particular case, this intraretinal hemorrhage, there was an intraretinal hemorrhage and a pre-retinal hemorrhage in combination. And it's the pre-retinal hemorrhage that actually takes time because the vitreous is much thicker. So it's just hard for the body to absorb this vitreous hemorrhage.
Thank you.
Pre-retinal hemorrhage. I hope that was clear. I actually have, I would like to answer all of your questions, but I have a 3-minute video that I actually just want to show you after I'm done. Go ahead.
Right, let's go to Cesare.
Hello, Dr. Sa. It was a great talk. Thank you very much.
Thank you.
I have a small question. If the hemorrhages dissolve so rapidly in small babies, is there a way to distinguish or speculate if this was a singular incident or if this is like a chronic process? Is there a way to say?
Yeah, I wish there was a simple answer to that, but it's actually a little bit more complicated than that. So, for example, if you see areas of a small retinal hemorrhage and a larger retinal hemorrhage of different layers, then you can pretty much speculate that this abuse had been ongoing. So you got part of the intraretinal hemorrhage that's going away, and then you have new intraretinal hemorrhage that's larger, that's forming. And also, if you see pre-retinal hemorrhages, diffuse pre-retinal hemorrhages with small intraretinal hemorrhages with a subretinal hemorrhages, so then you can speculate there's probably you can speculate this is more of a chronic problem. But just in general, just FYI, intraretinal hemorrhages take about a week to resolve, just on the average. Depending on the size, it does get smaller and smaller and smaller. But so if you have small, medium, and large all in one retina, then you can speculate that this is an ongoing process. The pre-retinal hemorrhages can take 1 to 2 months for it to resolve. So based off of that, you can make some guesstimations, but it's not an exact science.
All right, we had a wonderful conversation, so let's just close it with comments from Dr. Swaru.
It's really not a comment, but Donny, I'm just fascinated by your talk. I don't understand anything, but I got 10% of it. And I think I didn't know just so many things. I was just curious about this resolution. Being a geneticist, I'm always reminded of Francis Collins' one talk where he said everything is genetics, even trauma is. And his answer to some questions was that response to trauma is always different in different individuals, which could be genetically predisposed. It could sort of in some way, genetic. And I'm just wondering if you have seen in your experience that there are kids where things resolve very quickly, whereas in some other cases, even if it's a small hemorrhage, it takes a lot longer. And do you think that it could have some sort of genetic component? I'm just curious. I mean, it's just naive question, but I've just, since you are expert in this, I thought I will ask you.
Yeah, Anand, that is an excellent question. That is not something that I thought about, but that's something that I think I should put more thought into. But yes, you're absolutely correct. There are some babies where the retinal hemorrhage resolve within 2 days, and there's some that just takes forever. As a matter of fact, there are situations where we have to actually go in and take out the blood because it just is not going away. Because it's blocking their visual axis and it's actually resulting in amblyopia and a lazy brain. So I do think that there's some genetic component to it, but also I want to go even one step further. When I say genetic component, like we talked about public health. Unfortunately, people who have been abused tend to become abusers. People abuse animals tend to abuse humans. So this is a public health issue, and that is actually the reason why I actually developed this 3-minute video that I would love to share with you. And I'm going to talk as I'm showing this video.
Approximately 1,300 babies are
So,
shaken. Most often experiencing the inside of the eye.
So this video is a virtual reality that we created. So here.
We will enter through the pupil, the black spot in the center of the eye.
And we're trying to educate the general public.
And images from the baby's world into
we can't really hear the soundtrack very well, Donnie, but that may not be important.
Yeah, it's not that important.
Virtual reality.
Yeah, it's not that important. So
see key structures inside the eye. Now, the retina is evenly colored and is lined with blood vessels and nerves.
So I'm just going to show you. So this is a virtual reality model that we created. So when you wear this, you're inside the baby's eyeball. Okay. And then you're seeing this baby and you're going to be picking up this baby and you're going to shake this baby. And then as you shake, because the sensors have, your handpiece actually have sensors, it's going to register how hard you're shaking. And then you're going to see the physical manifestations of your shaking. It's more of an educational video.
Layers of the eye connect to the optic nerve, the yellow spot that looks like a sun. Remember, the optic nerve collects images from the eye and carries them directly to the baby's brain. Now we will see what happens when a baby is shaken.
And you can see the full excursion of the head.
This speed may cause damage to the brain.
I mean, you can see that that's exactly what happens. And then as you're shaking, the hertz is being monitored. Like it actually tells you exactly how fast you're shaking the child.
Eyes, the hemorrhaging to do the shaking. Therefore, greater physical.
You can see this shaking. So anyway, so it's a virtual reality model that we actually have developed with the help of engineers. And it's actually, it's more for an educational material. And I actually took this to the zoo and I was gonna have this as an educational material at the zoo, but the executives at the zoo said, no, this is like, we're a happy place. We don't want any unhappy, anything that can actually make people unhappy. So it's like, so that's where we are. So I think it's very important for us to be aware that this actually is happening. And I think we, I'm going to be doing more and more research, not just on abusive head trauma, but my focus is actually more going into sports-related ocular injuries and the force that it's being transmitted to the eye, and how different types of protective eyewears can actually have a protective roles. And we actually just submitted that paper. So there's going to be a lot more stuff that you'll be seeing on this particular topic. So Well, thank you very much for your time. And if you have any, you have my email. So please, if anybody have any questions or thoughts, please feel free to contact me anytime, please.
Thank you very much, Donny. Until next time, next week, Friday, 8:30 sharp, Connie Sepko will tell us about genetics on special request from Dr. Swarup, I guess.
Thank you. Thank you, Chris.
Very nicely done.
Thank you, Chris.
Excellent.
Beautiful, beautiful.
Thank you. Thank you.
Even my dog likes it.